guest. Do keep your questions coming in throughout the next hour. We've already had a lot of fantastic questions, so thank you very much for that. And we'll try to get through as many as we can. Andrew Lansley, thank you very much for making time for BMA members. I want to get straight to it because we've had a lot of questions and ask you, what do you think of it so far, really, the reaction to your bill?
Well, remember, it isn't about the bill, it's about the modernisation of the NHS. It's about a whole process of putting, well, I mean, you know what the purposes are. The purposes are very straightforward. It's firstly to have an NHS which puts patients right at the heart of everything we do, that the principle of shared decision-making, of no decision about me without me, should be at the heart of the whole service. Secondly, it's about focusing on outcomes. We've been through years when there's been a focus on processes and targets and ticking boxes instead of really going through the painful necessity of saying, well, what is it the results we're looking for? And in many cases, actually, we hadn't in the NHS been absolutely clear about what the outcomes were or measuring those outcomes, and we're focusing on the outcomes and delivering those. And the third is of the white paper is the transfer of responsibility close to patients and into the hands of the frontline clinicians, the doctors, nurses, health professionals who are actually responsible for delivering care. Because there is a central purpose here, which is that the people who are responsible for delivering care to patients should also be leading the task of designing services to make that happen. Now, the bill is about bringing these things into effect and making the changes that are necessary for that, and people have got very focused on the structural changes that flow from that. But as far as I'm concerned, it's always been form follows function, and the function of what we're aiming to do is very straightforward. It's about those three things I just described, plus the strengthening of democratic accountability in local authorities and the transfer of the lead for local public health improvement into the hands of local government, who themselves, of course, have a principal responsibility for many of the wider social determinants of health.
Now, at least a third of the questions have been about one thing. Where is your evidence for going through with this reorganisation, or whatever you want to call it? Where is the evidence that this was a good idea?
Well, there are many things that go to form part of the modernisation process. So, for example, what I've said about the involvement of patients, I think is very well evidenced across health economies around the world, that the more patients feel that they have good quality information about the nature of the care being provided to them, the treatments that are available, the options that they have, what happens if things go wrong and how they can influence their care, has a big impact upon their patient experience and consequently upon outcomes.
Isn't it possible to achieve that without reorganising the whole system?
Well, the principal thing I think people focus on is the question of physician-led commissioning, which in British circumstances is general practice-led commissioning, although I think it's quite important to emphasise this is not general practitioners operating in isolation. There is a range of evidence where that is concerned. There was the evidence in this country of fund holding and the impact it's had. There's been the evidence over recent years of practice-based commissioning where it's worked well, and there have been places where practice-based commissioning groups have made positive progress. There's been evidence in other countries of where physician-led commissioning can have a very positive impact. There's also all of those experiences in other countries have given us evidence about the things we need to guard against. So, for example, where GP fund holding was concerned in England, we knew we had to be careful to make sure that we didn't fragment the system so that individual practice were trying to manage commissioning budgets. We knew we had to come together in commissioning groups. What back in 96, 97 were the locality commissioning groups that were coming together. We knew that we had, looking at the evidence from other countries, we knew it had to be something where, because we are able to focus on clinical commissioning, that we can really focus the physicians on that task, because actually in other health systems they very often get distracted by the insurance system into things which are not relevant to their focus. But I think the evidence of physician-led commissioning is that it does deliver more appropriate and more effective care.
OK, let's read to you some of the evidence questions. You are introducing a nationwide change in the delivery of healthcare without any evidence, without a trial or pilot of any kind, and without any apparent antidote. If a doctor did this with a new medicine, it's likely they'd be struck off. What makes your plan above such basic safety? Just, if I don't mind, I'll just put two, and then you can answer them together, because we've got so many. That question was from Nick Flatt, who's a consultant anaesthetist in Wigan. And also, Andrew Lawson says there is now evidence that all of the market reforms of the past have have done little to alter outcomes. What reason can we have for thinking that this will be any different?
Well, first to the question, no pilots. Well, just consider for a moment what it is that the modernisation process is actually about. Leaving aside the issue of the engagement of patients, which I think in itself is very important and very widely supported, general practice-led commissioning activity, there have been not only the example of front holding, but the examples of practice-based commissioning. We've got a lot of evidence and, in that sense, piloting to work from. But nonetheless, we are proceeding on the basis of a transition which gives the new commissioning groups who've come together, and now it represents something over 2/3 of the country, the opportunity to create pathfinders and to have a learning network between them. When you look at payment by results, there is a lot of evidence, not just in this country, but across health economies all over the world, the most developed health economies, that we need to move to a system of payment by results, one that isn't just payment by activity. I've had those discussions with Australian health ministers and other countries. The focus on, for example, the transfer of public health responsibilities to local government, this is in the English context. I don't think that's not just a problem that we know we can deal with better by transferring into local government. We know, as for example Michael Marmot, who's president of the BMA, made clear, the transfer of public health responsibility to be able to tackle the wider determinants of health is going to have a very big impact. A lot of this, I think, is about economic regulation. Because the question is, can we deliver better health care in circumstances where we focus on quality and measuring quality, but at the same time we do encourage new providers to come in and to offer services as well. I'm absolutely convinced that's right, and actually as you look at other systems, the Dutch or the German system, you do see a plural system of health provision. Nobody in France, for example, where the patient experience is the highest anywhere in Europe, the positive patient experience highest in Europe, thinks that the French government has to own all the hospitals, and it doesn't own all the hospitals.
The practicalities, though, are alarming a lot of doctors, and you must have sensed a change in the atmosphere amongst many doctors towards this. You do use that example that a lot of commissioning groups now have come forward, that there are lots of pathfinders as evidence that all of the doctors within them are in favour. But what it actually means is that the doctors are getting on with it, not necessarily that they don't have concerns.
Well, you just had a question from Wigan. I went to the Northwest, and I went to witness at the invitation of the local medical committee, and GPs came together from Wigan and from Halton and from Knowsley and from Kirkby and from Widnes and all around, and this was in the autumn of last year. And I think it'd be fair to say that the practice-based commissioning groups there where they came together, 300 and something GPs, with the objective of saying, we want to be pathfinders, we want to do this. Now, of course, not everybody is enthusiastic, and I've seen from the outset people who find change difficult. And the BMA, to be fair to the BMA, they have in this respect been consistent. Under the last Labour government, when there was an any willing provider policy, they opposed that, and they oppose the same thing now.
But they're not just blanket opposing things, are they? They're opposing detail, since the detail have come out.
What I said is they oppose the any willing provider policy. Of course, to be fair to the BMA, when we published the white paper, they quite rightly said they support patient engagement, they support a focus on outcomes, they support greater responsibility for frontline clinicians, and they supported general practice-led commissioning.
Dr. Christopher Halfpenny asks, assuming the Health Secretary has not been blind to the enormous but invariably uncosted and unresourced burden of previous reorganisations, what attempts have been made to account for the unavoidable inefficiency, risk to patients, waste and staff time lost that the proposed changes will unnecessarily incur?
Well, we looked very carefully during the course of the consultation because, of course, remember the white paper was published in July. We had a 3-month consultation. We had over 6,000 responses. When we published the bill, we published the impact assessment, and there is a very detailed calculation that lies behind that, the results of which suggested that the cost of reorganisation would be £1.4 billion. The savings derived from the reorganisation would be £1.7 billion recurrently. So by the end of this Parliament, so by 2015, that's a saving of £5 billion, and there are further savings beyond. Now, people say, oh, but all reorganisations always end up costing more. But remember, in terms of reorganisation here, this is mainly about taking out tiers of management in the NHS. We're being watched by a lot of doctors, and I think there's, from my experience over 7 years at least now, as Shadow Secretary of State and Secretary of State, is right across the NHS, there are doctors in hospitals and in the community, in primary care, who have thought that the NHS is over-managed, not that it's just well-managed, but actually it's over-managed. There are too many bureaucrats, there is too much administration. We have to cut that back. Now, principally, the reorganisation is the consequence of transferring greater commissioning responsibility to local consortia, foundation trusts taking responsibility for themselves, focusing the responsibilities nationally and regionally into the NHS Commissioning Board, saves us a great deal of money in management costs.
It will only save us money, though, if those managers and the jobs that they do not go away, and the roles that they play do not fall into a vacuum. There are many concerns amongst GPs that perhaps they don't have all of the skills that you are asking them to have. Let me just sum it up with one question from Dr. David Berger, who says, you want us to take on the awesome responsibility of commissioning NHS services. This is going to be a lot of work, a lot of responsibility. It will involve us making £20 billion worth of cuts on your behalf. It will place us in a position of direct conflict of interest with our patients. Most of us have no expertise in this area and less interest. We are not commercially minded. Meanwhile, you're assaulting our pensions and freezing our pay. Why precisely do you think we should be enthused to take on GP commissioning?
Well, I don't think since everybody above £21,000 in all of the public sector is having their pay frozen, I don't think that is, in this specific respect, a relevant consideration. I do think the nature of the question implies a lack of understanding of what it is we're trying to do, because these are not £20 billion of cuts. This is cumulatively over the next 4 years, trying to arrive at the point where we have made savings by designing services more effectively, in order then to be able to reinvest that. So there are no cuts at all. The budget of the NHS over the next 4 years...
I think the people who are on the front line would disagree with you.
Well,
because they're feeling the cuts.
Well, hang on a minute. Let's actually look at the facts, because the facts are that the government is providing £10.7 billion extra over the next 4 years for the NHS. Now, in any specific part of the NHS, you might be in a hospital where, of course, one of the consequences of the changes that we need to effect might well be that there is reduced demand for hospital services, there is a change in the character of where services are delivered. That's precisely what Dr. Berger, I think, is saying he can't be involved in, that somehow clinicians, doctors and nurses working in the NHS are incapable of designing clinical services. I'm sorry, I don't agree. I have plenty of evidence from my own eyes that when GPs and nurses and hospital specialists get together and design services, they are better at doing it than simply one set of managers talking to another. If you go back to a document published by the National Primary Care Development Centre in Manchester University, who looked at the best examples of care close to home pilot schemes, the best ones were the ones that were essentially devised and designed between community clinicians and hospital specialists, because that actually gives the combination of people who understand primary care and accessible services locally, and people in the hospital who are, in effect, guarantors of the whole pathway and the quality and the specialisation that goes with it.
That's all very well if that is actually what happens when the consortia decide how they're going to organise themselves.
Well, why should it not happen, since they are going to be able to make those decisions? If you go around the country, I know you're going to say, oh, there you are again, saying the Pathfinder consortia are actually your answer to these things. But yes, they are, because they are doing this thing. You can go to Bexley, and the clinical cabinet in Bexley is redesigning services. You can go to Northampton, and NEN Commissioning have redesigned already the structure of services they provide to their patients with long-term conditions who had the largest number of emergency admissions. You can go to Cumbria, and they've redesigned the structure of local services. You can go to Somerset, and they've redesigned the structure of COPD services in the community. They are doing these things. And actually, of course, they need people alongside them who help them to do it. There will be managers, there will be accountants, there will be people who do contract monitoring, there will be lots of support, but at the same time, the question that people in the NHS, particularly I think many of the doctors are watching us, has to say, who would they rather were leading the design of services in the NHS? Would they rather actually it was done by managers in circumstances that very often cause clinicians to say, you're not listening to us, or clinicians who lead it, who then are able to say, yeah, and we know we need managerial support and expertise alongside us, but who's on top? Actually, the people providing the care need to be leading it.
A lot of the doctors who have written in for this evening have not been questioning necessarily the theory that it is a good idea, that they are the experts and they know it should happen. The practicalities, though, are a very different thing, aren't they? Because if you are getting rid of swathes of managers who know how to do the job and have become practiced at doing the job, if they are not necessarily including consultants, so Dr. Ali Ahmed has put in a question this evening saying, why are you not including consultants in this? That means there is evidence out there that some of the consortia are not yet including
consultants in hospitals are not included in commissioning now, necessarily, are they? I mean, you don't go to a primary care trust and necessarily find consultants involved.
But that's because you have managers who understand secondary care, and now you're going to have GPs who don't necessarily.
How many consultants have I spoken to in hospitals providing things like mental health services or cancer services, who have said to me, one of our main problems is that the people who are commissioning our services don't understand the service we provide. I sat down with people from the Motor Neurone Disease Association and the people who treated them just the other day, and they said one of our main problems is that the PCTs don't understand the service we're providing. We have an opportunity here, and the opportunity is for the commissioning of services, the design of services in the NHS, to be clinically led. Now, you're saying, I'm excluding consultants. You're not.
Not me,
I beg your pardon.
doctors.
Yeah, somebody said, I'm not excluding consultants. What I am saying, however, is that inside the NHS there is a unique characteristic of general practice, not just general practitioners, but general practice, which is that they are the place in the system where we have not only a responsibility day by day for the individual care of patients, but a population health responsibility. That is why they are the logical place from which to lead the commissioning of services. But the commissioning consortia that I'm talking to are expecting to involve other health professions in the community and the clinicians in the acute and other sectors in order to be able to manage their commissioning more effectively. And frankly, you mustn't leave out of account either the involvement of local authorities in the health and wellbeing boards. So to that extent, there is all the characteristics of what really makes these things work, which is clinical leadership, managerial support, democratic accountability, and seeing the whole system together in the local health and wellbeing boards.
More questions from doctors. Dr. Jean Quinn says, can you explain to me how GPs will manage the conflict of interest between being both providers and purchasers? And I should say similar questions came in from Dr. Chris Tilley, who's a GP in Mevagissey, Dr. Tim Roberts in Leeds, and also Simon Piper, who's in Guildford and Surrey.
Right. The answer is that will be managed because the commissioning consortium itself, as a statutory body, is not able to be a provider. GP practices can be providers, groups of GP practices can be providers, but insofar as they provide services, they will be commissioned and contracted with by the consortium. So to that extent there will be transparency. And this is one of the things that we knew was wrong with GP fund holding in the past. There was potential for conflict of interest. It's why we've designed it to take that out.
But the difficulty for the GPs is that they are going to be making decisions on where the budget goes, where the commissioning goes, but they are also therefore, going to want to make choices or help their patients to make choices for the best providers. Dr. Simon Piper puts it very well. He says, I'm liable for any deficits at the end of the financial year, and the budget for care is at the whim of political expediency and is likely to vary or be predictable. I face a dilemma when faced with a patient who needs a very expensive treatment. Do I prescribe appropriately but expensively, refer for an expensive procedure, or compromise because of my personal finances are in crisis?
Well, firstly, there is a complete misunderstanding. Individual GPs and individual practice, and indeed the consortium itself, is not directly financially accountable on a personal basis for any deficits that occur in relation to their commissioning budget on behalf of patients, any more than the directors of a primary care trust or the medical director of a primary care trust is personally responsible if a primary care trust overspends. So I think that there is a misapprehension there. It doesn't work like that. The system will not be devised so that surpluses on the commissioning budget, on the patient care budget, can be redirected to the benefit of individual GPs or individual practices, but neither are they directly personally responsible for those deficits. Now, at the moment, GPs or indeed other doctors who are making clinical decisions about patients are doing so with an understanding that there are financial consequences and resource implications that flow from it. If people are telling me that they're ignoring those as though they don't exist, well, I think probably that's an abdication of a professional responsibility. If you look back at what the Royal College of Physicians said when they looked at modern professional responsibility, actually understanding the nature of the population consequences of the use of resources to deliver the best health care was one of those professional responsibilities, and that is also in the GMC code.
But you must be able to see that it may cloud their judgment if what they're concerned about is the budget and a shrinking amount of money that's available.
No. Well, firstly, it isn't a shrinking amount of money, it's a growing amount of money, because there's a £10.7 billion increase, and next year, on average... No, that's not true. On average, across England, primary care trusts in the next financial year will see a 3% cash increase in the money available to them. Full stop. Now, how they use it may mean there are changes in how it's deployed. But the second point is this. The only incentive that individual clinicians will have who are part of general practice or a consortium when making referral decisions, the only incentive they have is to improve the quality and outcomes they have for patients. The quality and outcomes framework is already such a structure that is designed to incentivise general practice to deliver better results for patients. The commissioning consortium will have likewise a commissioning outcomes framework that I hope will be complementary to the quality and outcomes framework, the purpose of which is to incentivise the delivery of improving quality and outcomes for patients. So that they don't have in that sense, we all have a responsibility, at every part of the system to use resources as best as we possibly can to deliver the best result for patients. That is actually just part of everybody's, the optimum level of results for patients using what inevitably is a finite amount of resources. But I can't imagine that anybody in the NHS actually believes they're not in that position now.
Along the same lines, Dr. Louise Irving put in some concerns, which I summarised, but she basically wants to know who is going to make the big decisions about contracts and tenders. Is it going to be sifted by the GPs, by patients, or will there be a bigger role there for Monitor?
Oh, well, no, the contracting process will be one that is led for local health services by the commissioning consortia. For regional and specialised commissioning, it will be done by the NHS Commissioning Board. In that sense, but remember, I hope we're moving increasingly to a situation where payment by results is improved, standard contracting is available, standard contracts are available from the NHS Commissioning Board. So to that extent, if we shift also payment by results so that it extends more into the community, it will be possible for the commissioning groups increasingly to have contracts with all of the willing providers. And they can do so on the basis of a national tariff or a local tariff, but a tariff basis, and with the benefit of standard contracts that increasingly incorporate the national quality standards published by NICE and made available through the Commissioning Board.
Your reaction then, please, to the research published by the BMA last week, which showed that 89% of more than 1,600 doctors surveyed in association with Ipsos and Mori are convinced that increased competition will lead to fragmentation, and 65% that it will reduce the quality of patient care.
Well, there were also a lot of other results which actually suggested there are many things that we are proposing to do through which I've already talked about, which are supported, so including engagement of patients and engagement of frontline clinicians. Let's remember, if doctors and nurses across the NHS actually think there should be a transfer of responsibility into the hands of frontline clinicians, we shouldn't be surprised if that's the direction in which I'm going as well. Does it lead to fragmentation? I mean, if people are constantly told, in the NHS, well, if you have competition, you have fragmentation, they might actually believe it. It isn't true, however, because if you go and talk to people in any other service, including in the private sector, and say, does competition lead to fragmentation? They'll say, no. It gives us what we're looking for. It gives us value. That's what we're looking for. Now, in the context of the NHS, what we're looking for is improving quality. So the competition that we're looking for is competition on quality. And increasingly, by extending payment by results and specifying what that quality looks like, the commissioning consortia can contract for the quality services they're looking for using fixed tariffs. At the point at which patients exercise choice or an individual doctor makes a referral, the price of different providers of a service will be the same, because that will be determined through either the local tariff or the national tariff.
And you have tabled this amendment, of course, to the bill, which has changed that, hopefully, and will hopefully avoid price competition.
It's clarified that that is the position. The point was that what people, I think, didn't understand was when we said maximum price, that somehow that would translate into different providers, Hospital X over here and Hospital Y over there, offering a different price. Well, there's no point in that from my point of view, because what I'm aiming for is quality. And remember, I don't want to be in a position where individual doctors making individual referrals are having to trade price against quality. They should always be choosing on quality. And patients exercise choice. It's a free service available to them free, so they will be exercising choice on quality too.
William Ibster says, why does Secretary of State ignore economists' evidence that competition lowers the quality of healthcare?
Look, I'm not ignoring it. The point is, we've looked at this. In the early 1990s, there was an internal market in the NHS which effectively did allow for price competition. The effect of it was to undermine quality. So that's not what we're doing. We are having competition based on quality. We are having the use of market mechanisms, but in order to drive quality, and the national tariff and local tariffs will be the basis upon which that competition takes place. So in effect, and actually it was the Department of Health who, I think, commissioned Dr. Carol Popper to undertake some of this work. We are looking at what, as far as we are concerned, is the evidence. And the evidence says you have to have a strong focus on quality. We've got the Care Quality Commission, who set essential levels of quality and safety. We've got a duty to improve quality laid upon all the participants in the system, and we have a structure of competition, while Monitor drives out inefficiencies in costs by the application of regulated prices to each individual clinicians or consortia making decisions about their local design of services. They will not need then to be using price competition, because they've got a regulated pricing structure that gives them hopefully an efficient basis upon which they then have competing providers based on quality.
There is a specific question here from Adrian Ball, who's the lead clinician for cancer, breast, head and neck at Surrey and Sussex. He says treatment of cancer requires a national strategy to ensure that standards are maintained and equivalent across the country, that access is unrestricted, that expensive treatments like radiotherapy are distributed accordingly to population needs, and that new treatments are introduced fairly. How will devolving these decisions to GP consortia ensure these aims are met?
Well, in two ways. Firstly, because it does require a strategy, and indeed we have recently, last month, published the cancer outcome strategy, because actually if we want to deliver the best cancer outcomes, we need to do more than just improve the quality of NHS commissioning. We need to improve awareness of cancer. So, a month or so ago I was in Bedford launching a cancer awareness campaign across the east of England as one of the pilots we have. That was particularly focused on bowel cancer. There was another in the southwest, I think, also focused on lung cancer. We need to improve access to diagnostic tests in the community. We need to improve screening, which is why we've committed to support FlexiSig. We need to improve public health, because the greatest potential impact on cancer rates in the long run will be things like reducing smoking and improving diet and improving activity. So all of those things, so there is a strategy. Now, from the point of view of commissioning consortia, there is an opportunity here. We haven't actually talked about the fact that there is a transition going on here, but the Pathfinder consortia, who are coming together now, are doing so with 2 years. It's more than 2 years away before they take the formal legal responsibility. They are focused at the moment on thinking about how they can design clinical services most effectively. Where you look at something like cancer, there is an opportunity here. At the moment we've got effectively lead PCTs who do commissioning for cancer, and they are of variable effectiveness across the country, as are cancer networks. What we need to do is to strengthen the cancer networks, strengthen the commissioning alongside them. I know the GP-led commissioning consortia fully understand that in addition to specialised commissioning, there is a need for them to work together in order to have what is effectively the right size of population for commissioning expertise, and they can either use commissioning support organisations or lead commissioning consortia, then to, as it were, mirror the cancer networks in a way that then delivers stronger commissioning in the future.
And is the evidence that's coming back that you're finding so far when you're going out and talking to the Pathfinder Consortia, is the evidence that they are including the secondary care consultants?
Yes, that's my own personal evidence. I mean, for example, it wasn't actually even a Pathfinder Consortium, but when I was in Bedford doing the cancer awareness launch, because I was there, the local Horizons Consortium, which was based on a practice-based commissioning group, came together, and there I was with the medical director of the hospital, Bedford Hospital, with the local authority came, the director of public health came, people all sitting around a table. And actually, in many places where I've been, particularly where local authorities are concerned and the responsibility for social care, sometimes this is the first time they've had that complete set of people who are responsible for delivering improving health, sitting down, designing the services together.
There is some concern coming through in the questions now about you dismantling the PCTs. I think there is a feeling that there is a bit of a brain drain going on in some areas. There's a question here from Judith King who says, I'm not happy with the idea of commissioning. I think we need local specialist input too. And what is the benefit in dismantling the PCTs? And Dr. Iriana Lovedale says, I'm a GP in Newcastle. Currently, approximately 3,000 people work at the PCT. When this goes, GPs are to take their work over and need to continue as clinicians as well, albeit maybe part-time. How is this not fantasy?
Well, first thing is, I'm planning to reduce the number of managers and administrators in the NHS by something approaching 25,000. It's a large number, but it's actually technically only halving the number. And across the NHS, there will continue to be a level of managerial and administrative support in numbers and costs that is broadly equivalent to where we were in 2004, 2005. So, and I don't remember people then saying, we're woefully undermanaged. What, of course, has happened in primary care trusts in the subsequent few years has been an absolute ballooning in the amount of administrators, plus about £250 million a year in the last year, 2009-10, for which, prior to our coming into office, they spent £250 million on top on purchasing services from management consultants. I'm afraid the answer one has to come to is that having 50,000 administrators in primary care trusts was not the most effective way to deliver services to patients. So we are going to reduce that. It's going to be a lot of the contribution. When we talk about saving £20 billion overall in the NHS, remember a considerable part of that, about 10% of that, is the consequence of cutting out tiers of administration. I have no doubt that if we focus on the people who can deliver the managerial and administrative support that we really need, we will get the people we need. We have reduced, so far we've got the data for the first 6 months since we came into office last May. And in those first 6 months, as it happens, there's been a reduction of about 2,000 in the number of managers, from about 36,000 to 34,000. So it's hardly vast numbers leaving. At the same time, we've had an increase of over 2,000 in the number of doctors in the NHS. From my point of view, I am determined, as I said before the election, that we will see a relative transfer of resources from back office, admin, managerial, tiers of management into frontline services. And that's already started to happen.
Some of the evidence that is coming through here is on specific cases, and just bear with me because there have been some examples that have come through from the front line that I think are very valuable for a lot of people. Dr. Paul J. Hobday has written to tell us about what's going on in Maidstone, which I know you know a lot about, where you have decided to close the consultant-led maternity unit. I'm just going to summarise. A survey in August 2010, he says, showed that 95% of local GPs opposed the closure of that unit. This has just been repeated with similar results. These GPs are all members of the local commissioning groups. The public are overwhelmingly against the closure, with a 20,000 signature petition being delivered to Downing Street. And most GPs surveyed think patient safety will be made worse. How is this consistent with putting GPs in the commissioning driving seat? How does it fit with your slogan for patients, no decision without me? And how does closing the local unit increase patient choice?
Well, I've met Dr. Hobday, of course, when I visited Maidstone, and I met, around the table, representatives from general practice consortia. Of course, we're in a position, and I freely acknowledge it was intensely difficult. It's one of the reasons why I went and had to sit around the table and have a conversation. Effectively, the conclusion I had to reach was that the decision had been made previously. The decision that really, in effect, took it out of our hands was the decision to invest the resources to establish the new hospital at Pembury, which, once that hospital was staffed and up and running and the resources were deployed there, it made it intensely difficult on the advice, clear advice of the obstetricians and other clinicians involved in the Maidstone and Tunbridge Wells Trust to carry on at Maidstone. There were competing views amongst GPs about whether this was the right thing or the wrong thing. There were differing views amongst GPs about whether a midwife-led unit should be maintained at Maidstone. What I'm very clear about in the decision that I reached was that, firstly, there was a strong view that paediatrics should be supported at Maidstone, and I made that clear that would happen. And secondly, that we should look at the evidence for a standalone midwife-led unit when we get the place of birth study later this year, and that GPs collectively, when they have responsibility for commissioning budgets, they can seek, you know this phrase about willing providers, they can seek willing providers. At the moment, frankly, I have to tell you, the Maidstone and Tunbridge Wells Trust was not a willing provider. They did not believe they could safely or viably maintain an obstetric service on the Maidstone site. If you don't have a willing provider, the GPs and I can think what I like, but I can't necessarily continue to provide it.
And I suppose the point really for the wider audience is when the GPs are in the driving seat and the local, you know, they're listening to local patients, isn't that an example of something that actually would have gone a different way?
It might have gone a different way. It might have gone a different way. And more to the point, actually, when you look at it, it wouldn't have been coming to me. The GPs and the local authority have a strong view in West Kent. I know they do. And actually, if they had been in the driving seat 5 years ago, which is pretty much when all this started, about 2005, if they'd been in the driving seat in 2005, they might have come up with a very different commissioning plan than the one that the Primary Care Trust at the time did.
OK, Kathy Bailey is a senior consultant paediatric rheumatologist in the Midlands, and she wrote in, this is clearly a very small specialised area of practice, but it's not recognised as a specialist service by many existing SHAs as a service to be considered for regional or super-regional planning and funding. Planning for equitable provision needs to be over an area larger than at present. How are specialities like this going to be looked at under the new system?
Yeah. Well, of course, this is a very interesting example because it is precisely outside the current national standardised criteria for national or regional specialised commissioning. I don't know about paediatric rheumatology's commissioning in detail, but I think it rather bears comparison with the conversation I had, as I was mentioning, with the Motor Neurone Disease Association. What the Neurological Alliance are doing for MND, MS and Parkinson's together, they are working together to say we want to put in place, as charitable organisations from the voluntary sector, we want to put in place a commissioning support organisation which we can make available to support commissioning consortia across the country if they wish to have a larger population as a basis for commissioning. I think and it may well be for paediatric rheumatology, that you'd be looking at quite a large population as the basis upon which you would have expertise. So I think one of the issues is to say to commissioning consortia over this coming 2 years, and with the voluntary sector and the hospital specialists, is it about time actually we started to think outside the box of it must be done at a regional level or national or local, that actually it varies according to many of the conditions we're looking at. For something like cancer, you know, there are some cancers that have to be commissioned nationally. There are some that can be commissioned with a population maybe of 1 million to 1.5 million. There are some which actually maybe others can be the subject of local commissioning perfectly reasonably because they are much more common cancers.
And are you finding that there is a mindset to include the voluntary sector and others here amongst doctors?
The voluntary sector believe there is a major opportunity here to improve the quality of commissioning. And at the moment, the conversations I know, because I've been a participant in them, have been with the Neurological Alliance, with the mental health charities who think the quality overall of commissioning for mental health services can be substantially improved, and the charities working with children with communications difficulties. All of those are working to try and put that kind of commissioning support in place.
There is a question about mental health, without just come back to in a moment if I don't forget. But one more specific example, because I think it's quite valuable for you to hear this from the front line. A GP in Yorkshire who wishes to remain anonymous says, I work in a practice in which one of our GP partners has taken on the role of representing the practice in the increasing numbers of commissioning-related meetings. Like many practices, we're really up against huge demand at present, and we're intensely busy. These meetings have reduced this GP's availability to patients. Backfill remuneration remains unclear, and even if funded, we find it near impossible to recruit locum GPs, an unsatisfactory solution in any case. There is no way that a temporary locum can replace the value of lost time of an experienced GP partner to our practice and patients. What should I say to my partner's patients when they complain about not being able to see this GP?
Well, I don't think that overall it is unreasonable for there to be a proportion. I think it will be a pretty modest proportion of GP time of a minority of GPs, not a majority necessarily, devoted to the business of trying to design services for patients, not just looking after, diagnosing and treating individual patients. I think, for example, if you're a GP with special interests in mental health services, take that example, you don't want just to be somebody to whom other GPs might refer patients on the basis that you have a special understanding. You want to turn that understanding of the interface between primary care and specialist services into the ability on behalf of all your colleagues to lead the commissioning of services. Now, does it all have to take place in committee meetings? No, it doesn't. Commissioning consortia can actually decide how they best do this thing. And in my experience, very often what that will mean is that time which at present is often devoted to trying to negotiate your way through primary care trust committees. Let's remember, we're not starting with a zero commitment of GP time to commissioning and to primary care trusts. A lot of GPs spend a lot of their time engaged in trying to get the primary care trust to do what they want it to do. So to that extent, a lot of that time can be devoted, I think, more successfully to establishing the right relationships locally and the right relationships with their local hospitals and healthcare providers in order to get the service that they want.
But it is a learning curve, and at the moment
Sure.
a lot of GPs are committing a lot of time to try and get it right
Yes,
for
they
their
are.
patients.
And there will be
primarily.
support for backfill, and that is important. I mean, the same would be true for, general practitioners who take responsibility in local medical committees. Nobody says we don't want local medical committees because GPs have to give up time to it. They say
But it is
part of our responsibility.
It is tricky for this doctor, isn't it, when
It
he
can be
hasn't got
tricky.
one of his partners
Of course
there.
it can, but there will be. I think we know we've had an increase in the number of GPs. We know in the future we will have an increase in the number of GPs. We know we need, for general practice, collectively, I say general practice advisedly because it isn't just general practitioners. Remember, it does extend to other health professionals as well. Collectively, they do need to come together. They do need to work out how they can give clinical leadership to this. But I actually think, notwithstanding all the practical issues that will be worked through, having clinical leadership of designing services for the benefit of patients is absolutely integral to people's professional practice.
Let's ask that mental health question before I forget. There is no name on this question, but it's cuts in benefits mean increases in the severity of mental illness. What provisions have been made within the NHS to account for this? And there have been other questions saying that you've perhaps missed a chance to include social care in the reform, so that the two are
Not
completely
included
interwoven.
social care in the reforms. I mean, I'm just astonished by that proposition. We've done more in the last 10 months to secure the integration of social care together with the NHS than had happened in the previous 10 years. The health and wellbeing boards in local authorities are going to have a place specifically where public health, social care and NHS services can be coordinated together. We made savings inside the Department of Health. Not only next year will there be £650 million specifically set aside within NHS budgets for integrating health and social care together to deal with issues like earlier intervention, more preventative activity with people with long-term conditions at home, more telehealth, more home adaptations, more community equipment. But in January, 4th of January, because we'd made savings inside the Department of Health's own budget, we had £162 million extra this financial year for precisely the same things, to try and deal with delayed transfers of care or the backlogs on community equipment or home adaptations that we knew we'd inherited. The integration of health and social care is going to happen much more rapidly in the future than it ever has in the past. And cuts in benefits, well, you know, what world are we living in here? We're living in a world where we know that as a consequence of dealing with the deficit, we are going to have to reform welfare. The principal driving force of Ian Duncan Smith's welfare reforms is that people should be better off in work than out of work. If you talk to people in general practice and in mental health services, what tends to lead to some of the comorbidities associated with mental health problems, it's actually very often the fact that people are out of work. It's the fact that they are in poverty as a consequence of being out of work. Worklessness is in itself one of the principal drivers of poverty and poor health. So actually the welfare reforms are designed to support that. And our reforms are designed to support it. When we published the mental health strategy, No Health Without Mental Health, just a month ago, one of the central planks of that was not only early intervention and more work with children and young people, but also the extension of talking therapies. You know, right across the board, 1.2 million more people, as a consequence of a £400 million investment over the next 4 years, will have access to talking therapies. And we know, because I've been to the locations and seen the services, that it's very often precisely people who have are at risk of falling out of work for a long period of time, who by early access to talking therapies can be reintegrated back into the workplace quickly.
Moving on, there is concern, perhaps filling a vacuum at the moment, about how the consortia bodies will be regulated, even audited, and how their competence will be monitored or policed. There is some concern around the detail for that. There have been questions from Drs Abdul Jalil, Mark McCartney, Hilary Pickles and Dr R.L. Simmons. Can you tell us exactly how much power the Commissioning Board and Monitor will really need to have in your mind over the consortia?
Well, let's separate. The NHS Commissioning Board is responsible for holding the contracts with individual practices and with the commissioning consortia. The commissioning consortia are statutory bodies. There will be the requirements of accounting for public money. The accountable officers will account for that, and the NHS Commissioning Board will hold that responsibility. So I don't think there's any vacuum at all. If people say, well, what is the process by which commissioning consortia will be held to account? Well, you can see in the legislation there is the responsibility for propriety and meeting their statutory responsibilities to the NHS Commissioning Board. There is accountability to the Health and Wellbeing Board locally for democratic purposes and for ensuring that their commissioning plans meet local intentions expressed through the local authority. And if they do things that the public have problems with, there is both Health Watch and the Overview and Scrutiny Committees who are able to exercise a role respectively for patients and the public in scrutinising what they do. So there's quite a lot of accountability safeguards built in. Monitor's job is simply to ensure that in this process of commissioning services, commissioners do not behave in a way that is an abuse that leads to detriment to the public interest. They can step in order to stop that happening. It's not that they tell, because I've seen a lot of nonsense being talked about this, that somehow Monitor is going to require commissioning consortia to tender services competitively. Look, under an any willing provider approach, we're likely to have less competitive tendering because you establish a fixed price and you commission for quality and you are willing to have a contract with the providers who can meet those standards and those prices. So you don't need to competitively to tender. It is already the case, no difference, it's already the case, if a primary care trust wishes to place a contract with a single provider or restrict the number of providers or guarantee a volume of activity to a particular healthcare provider, then actually they have to do so through a tendering process. The legislation doesn't change that.
What about your own powers when you're asked to step in? Will they be overly restrictive? No,
there is a very clear intention on my part to give the NHS, through the Commissioning Board and the Commissioning Consortia and through foundation trusts and all NHS trusts becoming foundation trusts, to give much greater autonomy. It is not complete independence. There is a difference. The Secretary of State, future Secretaries of State, must be able to continue to account for the resources that have been deployed. They must be able to step in if the NHS Commissioning Board or Monitor or the Care Quality Commission, for example, were clearly failing to exercise their responsibilities, and the legislation sets out those abilities to step in. What I think is an enormous difference compared to the past is two things. Firstly, that I can't, as in the future, as Secretary of State, be trying to tell the NHS what to do day by day. The principle is very straightforward. David Cameron set it out in 2006. He said, we want in future for politicians to tell the NHS on behalf of the public and the taxpayer what it is we're trying to achieve. Health outcomes as good as anywhere in the world, and to be clear what those outcomes are in the mandate that is set for the NHS Commissioning Board. But not to try to tell the NHS how to do it. Get out of the business of day-to-day interference. And the second big difference is transparency. Because at the moment it's not transparent. Most of what happens inside the NHS is part of inside a very large black box. If I went out and said to the public, do you understand how the NHS commissions services and spends its money? Do you think one person in 100 could actually explain this? I don't think so. This is going to be much more transparent. And from the public's point of view, the fact that the people who are working in their local general practice, with whom they're registered, with whom they have a relationship, are part of a transparent system where they make decisions about the design and quality of care that's provided to them, I think that is pretty much of an improvement on where we are today.
Sebastian Hendricks is a consultant with previous experience of German, Canadian, American and Austrian healthcare systems, and he says, I would like to know why the government is insisting drastic reform is needed in the NHS healthcare provision, but resisting all the suggestions to improve and reform their reform plans, and warnings from those knowing the health service. And just one other to add to that from Rebecca Bayel, who says, I accept that the NHS will need to make changes, but why is the Secretary of State not listening to the people who can make it work? There is a feeling out there that you're still not listening, that you're giving these politician answers and not actually listening to what they say.
I don't know where any of this comes from. Look, for a start, we have had successive Secretaries of State, very often, who arrived in Richmond House, in the Department of Health, with the power to change everything, and very often they did change things, and very often they didn't do so even on the basis of having spent some time finding out what's going on in the NHS. I mean, let's face it, I didn't arrive in Richmond House as Secretary of State without any experience of the NHS. I had spent 6.5 years as Shadow Secretary of State. For every person who sent a question saying, well, why are you doing this thing? You know, there are probably a dozen more who, over the last 6.5 years, have been constantly saying, if only they listened to us, if only they would realise that we could do things better if we had more responsibility at the front line. It's why things like productive care in hospitals makes a difference. It's why practice-based commissioning, where it's been done well, makes a difference, where general practice-led commissioning can make a difference, where new social enterprises being set up by community healthcare services can make a big difference because the staff are directly involved. Now, you might say, from my point of view, there is a principle at stake here. Yes, the principle is that the people working in public services should have more direct responsibility for the design of those services. Have we been listening to what people have been saying to us? You can track it back from the white paper through a 3-month consultation. When we published the proposals just before Christmas, there was a page of changes as a consequence of the consultation
just
responses. A full page of, a page listing of all the changes that we've made. We've introduced the legislation. You said a bit earlier when we were talking, you said, well, you've made amendments. Yes, we've made amendments. Do you know why? Because everything is capable of improvement, even the legislation we introduced to Parliament. And how are we doing it? We're doing it because there are organisations like the British Medical Association who said, we think the way the legislation is structured would lead to price competition, which would be to the detriment of quality. We never intended that to be the case. We didn't think that would have been the effect. But if we can amend the legislation to make it absolutely clear that competition is not on price but is on quality, then we're very happy to do it.
So you will continue to take their comments on board, and if they say that they're concerned about the way that the consortia are being organised and who is being involved and their budgets are wrong, you will take that on board?
Yes, of course. But there are points where we differ. Of course there are points where we differ. For example, the concept of any willing provider, of a charity or a private sector organisation as well as NHS-owned organisations, if they meet NHS standards within NHS prices, then they should be able to offer services to the NHS. Now, we're in favour of that. The Liberal Democrats are in favour of that. It was in both of our manifestos. As it happens, it was in the Labour manifesto. So for the British Medical Association to say we're against any willing provider and you, Parliament, should do what we say
I don't think they said that they're against any willing provider.
Yes, they have. They said they're against any willing provider. They have literally said that. And for them to say that and expect Parliament, having been elected with all three main parties elected on manifestos that said they were in favour of any willing provider, is actually rather to seek to undermine the mandate of Parliament.
But I think that doctors feel a little bit concerned when you seem to be making sweeping statements like that, because actually what they're drilling down into now is the detail, that they are against any willing provider. Actually what they're concerned about is the detail of how these things will work.
No, the BMA has said it is against any willing provider. I'm not making that. That's what they said.
Okay. Some will perceive you to be defensive in these things. But are you concerned at the levels of dissent amongst doctors at the moment? Because you can't make this work without them, can you?
When you say dissent, look, there are GPs who are actually getting on with it. There are clinicians in hospital who work in foundation trusts who think that the freedoms that are given to foundation trusts are important. There are people who are making this happen. There are local authorities across the country who are enthusiasts for taking on their public health responsibilities and for being more involved in the NHS. I know from experience over 6.5 years, I know two things. One, transferring greater responsibility into the hands of doctors and nurses and health professionals at the front line is something they seriously want to see happen. They're very much behind it. Are they apprehensive and sometimes antagonistic because either change is very difficult or people have told them that the consequences of our proposals are going to be things that they need not be and will not be? You know, we're in favour of competition on quality. There is a duty to improve quality on every organisation through the bill. We are promoting greater integration in terms of the delivery of services. I published an operating framework in December that for the first time made it absolutely clear that we're shifting the NHS tariff so that it can become a year of care pathway tariff rather than just individual procedures. I think there's an awful lot of the dissent that you refer to that is being promoted on the basis of a misunderstanding of what we're setting out to do, or in some cases a willful misrepresentation.
But here's a flavour of it. Richard Sloan has just put in a question saying, why does he think that spending 6.5 years as Shadow Secretary is of more value than someone like me who spent 30 years on the job?
I don't. Because actually what I learnt in 6.5 years, the basic proposition is I don't know. I am setting out for the Secretary of State no longer to tell everybody in the NHS what to do all the time. We reached the absurd situation. I remember it happening. I went to a conference of consultants, of ENT consultants, their specialist association a few years ago. And I remember the consultant lady from Newcastle who said to me, I just want to have a word with you because I'm very confused, because yesterday morning in the Sunday Times there was a story saying that the health minister, I think it was Norma Warner at the time, is going to tell us that we must do fewer adult tonsillectomies. And she said, and I am in charge of a multi-centre study examining when we do adult tonsillectomies, under what circumstances and how many we should do, and we haven't reported. We shouldn't be in that situation. It is not the business of a layman like me, or Norman in the past, or anybody else, to try and tell health professionals, who indeed do have 30 years, 10 years training and many years' experience, how they best deliver results. What I'm going to focus on is saying, look, we want to know that the outcomes we're achieving are at least as good as anywhere in the world. We're focusing our effort, and it's not just me doing it, it's led by, for example, Bruce Keogh and his team. And Bruce and colleagues in cardiac surgery had the benefit over the last 15 years of turning clinical audit into a systematic examination of the outcomes of cardiac surgery, the publication of those and the benchmarking of those against international experience. What's the net result? Actually, we have outcomes from cardiac surgery in this country that are literally amongst the best in the world. That's the direction we need to go in.
We're going to overrun, but I want to put the last question to you from a doctor. This is from Dr. Peter Fitton, who says the two main planks of your plans are that commissioning groups will be GP-led and that there will be less central direction. If we can deliver the first, how are you going to deliver the second? Just briefly, please. Because
the legislation is very clear. In the past, the NHS legislation more or less says the NHS at any moment is whatever the Secretary of State wants it to be. I could literally have abolished most of the primary care trusts without legislation. The point is that the purpose of the bill is to be very clear about the autonomy that hospitals, healthcare providers, GP commissioning consortia have, and the distance that is created between the political responsibilities and the professional responsibility.
I think a lot of doctors, it has to be said, are genuinely thankful that you do give up your time to answer their questions. So, Secretary of State Andrew Lansley, thank you very much. Of course, there have been a lot of questions that we haven't been able to get to, for which I apologise. We'll try and put a cross-selection of those to the Secretary of State, and I'm sure that he will look at them. Thank you very much for your time. You can Twitter me on Lime Green Media, and I hope to rejoin you again soon. Thank you. Good evening.